Welcome to Pediatric Case Review. Today's lecture is a comprehensive case-based review of allergic rhinitis, designed for general pediatricians. Allergic rhinitis is one of the most common chronic conditions in childhood, yet it is frequently underdiagnosed and undertreated, despite causing significant impact on sleep, school performance, and overall quality of life. We will work through 10 clinical cases covering recognition, examination findings, pathophysiology, including the immediate and late phase responses, diagnostic workup, classification, differential diagnosis, environmental control, pharmacologic treatment, and long-term complications. By the end, you will have a complete framework for diagnosing and managing this common pediatric condition. Let us begin. Question 1. A 7-year-old boy presents with a 3-month history of nasal congestion, sneezing, and clear nasal discharge. He has dark circles under his eyes and a horizontal crease across his nose. His mother reports he snores at night and has difficulty concentrating in school. Physical examination reveals pale, boggy nasal mucosa and clear rhinorrhea. What is the most likely diagnosis? Option A, acute viral rhinosinusitis. Option B, allergic rhinitis. Option C, bacterial sinusitis. Option D, nasal polyps. The correct answer is option B, allergic rhinitis. This case shows the classic constellation of findings that should immediately raise suspicion for allergic rhinitis in a child. Chronic nasal congestion with clear discharge and sneezing over months rather than days points away from a viral infection and toward an allergic process. The dark circles under the eyes are called allergic shyness and result from venous congestion in the periorbital region due to chronic nasal obstruction. The horizontal crease across the nose is known as the transverse nasal crease, caused by repeatedly pushing the tip of the nose upward in the so-called allergic salute. These two physical signs together are nearly pathognomonic. Snoring, sleep disturbance, and poor school concentration reflect the substantial impact on quality of life. Pale, boggy mucosa is classic for allergic inflammation, in sharp contrast to the erythematous mucosa of a viral or bacterial infection. Question 2. An 8-year-old girl with known seasonal allergies comes for evaluation. On nasal examination, you observe a pale, swollen nasal mucosa with clear secretions. The nasal septum appears deviated. Transillumination of the maxillary sinuses is normal. She denies facial pain or fever. Which finding is most specific for allergic rhinitis? Option A, pale boggy nasal mucosa. Option B, deviated nasal septum. Option C, clear nasal discharge. Option D, normal sinus transillumination. The correct answer is option A, pale, boggy nasal mucosa. This appearance is essentially pathognomonic for allergic inflammation and is the single most specific physical examination finding for allergic rhinitis. The pale, swollen, boggy turbinates with clear watery secretions reflect the underlying immunoglobulin E-mediated inflammation, mucosal edema, and increased glandular secretion. Compare this with infectious rhinitis, where the mucosa appears erythematous and inflamed with purulent yellow or green secretions, a completely different picture. Clear rhinorrhea suggests a non-infectious cause but is not specific on its own, since it can also occur in viral infections and vasomotor rhinitis. Normal sinus transillumination argues against acute sinusitis but does not confirm allergy. A deviated nasal septum is an anatomical variant unrelated to allergy and does not contribute to the diagnosis. The take-home point is that the color and texture of the nasal mucosa tell you the most. Question 3. A 6-year-old boy with allergic rhinitis is brought to your clinic during spring. His mother asks why his nose runs more in spring and why antihistamines help. You explain the immune mechanism. Which immune cell is primarily responsible for immediate hypersensitivity in allergic rhinitis? Option A, T lymphocytes. Option B, mast cells and basophils. Option C, neutrophils. Option D, eosinophils. The correct answer is option B, mast cells and basophils. Allergic rhinitis is the classic example of a type 1 or immediate hypersensitivity reaction. On first exposure, the immune system produces allergen-specific immunoglobulin E, which then binds to high-affinity receptors on the surface of mast cells in the nasal mucosa and on circulating basophils. On subsequent re-exposure, the allergen cross-links these immunoglobulin E molecules on the mast cell surface, triggering immediate degranulation. Histamine and other preformed mediators are released within minutes and cause vasodilation, increased vascular permeability, mucus secretion, and the sneeze reflex. This explains why symptoms appear within minutes of allergen exposure, why they are seasonal when the allergen is seasonal, and why antihistamines, which block the histamine receptor, can be so effective for the immediate symptoms of itching, sneezing, and rhinorrhea. Eosinophils, T lymphocytes, and other cells dominate the later phase, which we will discuss in the next case. Question 4. A 9-year-old girl with allergic rhinitis reports that her nasal congestion worsens 4 to 6 hours after playing outside during high pollen season, even after taking antihistamines. She develops nasal eosinophilia on nasal smear. What is the most likely explanation for these delayed symptoms? Option A. Immediate histamine release. Option B. Late-phase allergic response with eosinophil recruitment. Option C. Secondary bacterial infection. Option D. Acute sinusitis development. The correct answer is option B. Late-phase allergic response with eosinophil recruitment. This case beautifully illustrates the biphasic nature of the allergic response. The immediate phase peaks within minutes through mast cell degranulation and histamine release, producing sneezing, itching, and rhinorrhea. The late-phase response then develops 4 to 12 hours after allergen exposure and is driven by a completely different cellular mechanism. During the initial reaction, mast cells release chemokines and cytokines such as interleukin-5, eotaxin, regulated on activation, normal T cell expressed and secreted, and monocyte chemoattractant protein 4. These signaling molecules recruit eosinophils, neutrophils, and T lymphocytes from the blood into the nasal mucosa, producing sustained nasal congestion, mucosal edema, and increased mucus production. This late phase is largely resistant to antihistamines, which is why patients with persistent congestion need anti-inflammatory therapy, such as intranasal corticosteroids. Nasal eosinophilia on smear is a direct fingerprint of this allergic inflammation. Question 5. A 7-year-old boy presents with year-round nasal congestion and sneezing. His parents want to know what triggers his allergies. You consider diagnostic testing to identify specific allergens. What is the gold standard test for identifying specific immunoglobulin E-mediated allergens? Option A. Serum total immunoglobulin E level. Option B. Nasal smear for eosinophils. Option C. Skin prick testing or specific immunoglobulin E serology. Option D. Computed tomography of sinuses. The correct answer is option C, skin prick testing or specific immunoglobulin E serology. Skin prick testing is the gold standard for identifying specific immunoglobulin E mediated sensitization to common allergens such as pollens, dust mites, animal dander, and molds. It is rapid, inexpensive, and highly sensitive. A positive result is defined as a wheal of at least 3 mm greater than the negative control, surrounded by a flare reaction. Specific immunoglobulin E serology, often referred to by trade names like the ImmunoCAP test, is an excellent alternative when skin testing is unavailable, when the patient cannot stop antihistamines, or when there is extensive eczema preventing safe skin testing. Serum total immunoglobulin E is nonspecific because it can be elevated in many conditions like atopic dermatitis, asthma, and parasitic infections, and is therefore not diagnostic for any single allergen. Nasal smear for eosinophils supports an allergic diagnosis in general but cannot identify the specific allergen. Imaging of the sinuses plays no role in routine allergic rhinitis workup and only adds radiation exposure. Question 6. An 8-year-old girl has nasal symptoms only during spring and fall when tree and ragweed pollen counts are high. During winter and summer, she is completely asymptomatic. She has no year-round symptoms. How would you classify her allergic rhinitis? Option A. Persistent allergic rhinitis. Option B. Intermittent allergic rhinitis. Option C. Occupational allergic rhinitis. Option D. Vasomotor rhinitis. The correct answer is option B, intermittent allergic rhinitis. The modern allergic rhinitis and its impact on asthma classification, often referred to as the ARIA classification, has replaced the old seasonal versus perennial terminology because it better reflects the actual burden of symptoms on the patient. Intermittent allergic rhinitis is defined as symptoms occurring less than 4 days per week or for less than 4 consecutive weeks. Persistent allergic rhinitis is defined as symptoms occurring 4 or more days per week and for 4 or more consecutive weeks. This girl has discrete symptomatic episodes during the spring tree pollen and fall ragweed pollen seasons, each lasting only a few weeks, with complete remission in between. Her presentation fits intermittent allergic rhinitis. Classification is more than an academic exercise. It directly guides the intensity and duration of treatment, with intermittent disease often managed reactively and persistent disease usually requiring sustained anti-inflammatory therapy. Occupational allergic rhinitis applies to adult workplace exposures, and vasomotor rhinitis is non-allergic. Question 7.